So the topic today was cardiovascular risks and treatment options. In interest of time, I kind of just focused on some risks. I'll be more than happy to come back later next month or whenever to present on treatment options and sort of risk modification, if you will. So let's get started. Over the years, a lot of questions are thrown at me from my patients and from a lot of other people. Some of these I thought it was they were interesting enough and share worthy. One is, I get this a lot. I don't need a cardiologist. Nothing is wrong with me. I will not have a heart attack. I've heard that. Trust me. And my favorite, my annual physical was normal. But the more pertinent questions to ask are probably, what is the likelihood of somebody having a heart attack or a stroke? And how can we reduce that likelihood and prevent such events? And how can your primary care provider help you? And when should you really get referred to a cardiovascular specialist? I wanted to sort of focus on two, we're all very aware of, how prevalent cardiovascular disease is, the great morbidity and mortality burden that comes with coronary heart disease. But two factors that we tend to sort of overlook is the racial and gender angles to this. Obviously, coronary heart disease is vastly underdiagnosed and undertreated in women. Everybody is keyed into breast cancer and all the other cancers. There's a lot of PR campaign that goes with this, and obviously it's very important, but if you just look at numbers, it's not even comparable. So that's one. The second, the amazing thing that we notice is actually the cardiovascular mortality rate tends to be much higher in women than in men. And a lot of that is actually attributable to the fact that a lot of cardiovascular disease goes underdiagnosed, undertreated, undiagnosed, and untreated as well in many instances. And moving on to the racial and ethnic angle to this, cardiovascular disease is pretty much the leading cause of death for African Americans, Latino Americans, as well as several other racial and ethnic groups. And then when you put these two things together, African American women tend to be at the highest possible risk for heart disease, and really dying from heart disease. So that's just something that's very humbling, just in terms of statistics. So I wanted to bring those two things to everybody's attention before we move on to actual risk factors. So there are a lot of risk factors. We're all very aware of them, and we all are almost unconsciously geared towards recognizing them and modifying those risk factors. A lot of them are just traditional risk factors. Some of them are irreversible, like your age, gender, family history. Others, certain genetic predilections. Some of them are reversible, like your blood pressure, cholesterol, smoking, physical inactivity, and obviously diabetes, which is a big risk factor. And I will be focusing on that in just a little while. But one of the things that we need to keep in mind is, if you just focus on these traditional risk factors, you might end up missing a lot of patients, a lot of people who might end up having major adverse cardiovascular events. So in the next slide, you will see, let's go to the next slide and then we'll come back. Thank you. So in this paper from JAMA in 2003, you see that almost more than 60% of patients who had established coronary heart disease did not really have any risk factors, or perhaps had just one risk factor. So that's a significant number of patients that we could be missing if you just looked at conventional risk factors. Now, obviously, you do need some risk scoring, risk tool to manage your patients day to day. I would strongly recommend, let's go back to the previous slide, please. I apologize, I kind of put these slides in the wrong order. ASCVD risk estimator plus the atherosclerotic cardiovascular disease risk estimator that is widely available on the internet and in app form by American College of Cardiology. This is something that's very easy to use. You can plug in all those numbers, age, sex, race, etc., and it will give you the exact percentage risk of your patient. And then you can use that to classify as low, intermediate, or high risk. Usually 1 to 10% is low and 10 to 20% intermediate, and anything more than 20% is high risk. And then it will also give you suggestions as what you can do, and it will give you the possible impact of that therapy that would be seen. So I encourage all providers to use this. Next slide, please. Next. So some of the emerging risk factors that I wanted to focus on, because we're all very aware of the LDL cholesterols and all that stuff, and later on, when I come back to present risk modification, we can dig deeper into cholesterol and all those things. But there are a lot of emerging risk factors that could add to your armamentarium in terms of risk assessment of your patient. One of them is LDL particle size and density. Various lipoproteins like Lp(a), for example, high sensitivity C-reactive protein has a lot of data behind it. It is an independent predictor of cardiovascular mortality. Homocysteine levels. A big favorite of mine, coronary artery calcium scoring. We'll talk about that. Ankle brachial index. We'll talk about that. Carotid intermediate thickness as a surrogate marker of peripheral artery disease and atherosclerosis. Hemoglobin A1C levels. And also some other things that we may come across, but we may not readily recognize them as cardiovascular risk factors. Periodontal disease, erectile dysfunction, for example. These are all things that we could look at in our day-to-day practice and identify people that may be at more risk of cardiovascular disease. So I will focus on three things just to simplify and keeping in view time constraints: calcium score, ankle brachial index, and we will dig deeper into diabetes as a cardiovascular disease risk. Next slide, please. Next. So again, the various syndromes of diabetes, type 2 diabetes, type 1 diabetes, pre-diabetes. But one thing to note is that most of these complications from diabetes, the vascular complications, they tend to onset pretty early in the course of the disease, even from the stage of pre-diabetes onward. And one other thing that I would like to also talk about is metabolic syndrome that also sometimes tends to kind of fly under the radar. We typically diagnose diabetes, pre-diabetes, but we don't really label metabolic syndrome whenever possible. Next slide. So pre-diabetes, again, all the pre-diabetic conditions have been associated with increased risk of cardiovascular disease. That's been very well established, and I'm pretty sure we're aware of that. I just wanted to reiterate that. Next slide. A few words on metabolic syndrome. I don't want to go through the definitions of metabolic syndrome, but we're all very aware of that: waist circumference, triglyceride levels, HDL cholesterol levels, blood pressure, and fasting glucose. All of these are modifiable criteria, except perhaps for the HDL cholesterol levels, which we really don't have a whole lot of good options for. Next slide. But one interesting thing to note is metabolic syndrome confers a lot of risk of coronary heart disease. In fact, patients with metabolic syndrome, even if they're not diabetic, they have a higher risk of coronary heart disease than those who may have diabetes and no metabolic syndrome. Obviously, the combination of diabetes and metabolic syndrome just takes the risk level to a whole another level altogether. Next. What is also important is these individual criteria that go into determining the metabolic syndrome also individually confer risk of cardiovascular disease and risk of death. So which kind of tells us that even if you could modify one risk factor, you would be modifying their whole risk of major adverse cardiovascular events significantly. Next slide. So there are a lot of mechanisms by which diabetes leads to coronary heart disease. It's not just the hyperglycemia and the oxidative stress, but just by virtue of the fact that diabetes essentially induces a chronic inflammatory state and a chronic prothrombotic state in the body. We talk about this diabetic platelet, which tends to be stickier. It tends to express a lot of these receptors that are prothrombotic, secrete a lot of cytokines that lead to a lot of endovascular changes, leading to either subclinical atherosclerosis or even frank atherosclerotic clinical events. So there's a lot of these mechanisms that are going in these diabetic patients. Next slide. So one of the most important pieces of data to emerge in the last couple of decades is the fact that diabetics have the same risk of MI as somebody who just had an MI and who may not be a diabetic. So that's why we call diabetes as a risk equivalent, as a coronary heart disease risk equivalent. And which is why we have to treat diabetes just as though they've just had an MI, and because their risk level is that high, which is also why we recommend that diabetics right at first go onward, get on at least a moderate intensity statin, and then, in addition to controlling the blood sugars and stuff. Next slide. Obviously, not just diabetes, but once the other syndromes get added on, the risk just keeps multiplying and multiplying. Next slide. One of the really amazing things that I was always, struck by is the fact that a lot of these, things that we do, medications or whatnot, to modify the risk may or may not work in a diabetic. For example, aspirin apparently does not provide the same kind of cardiovascular benefit in diabetics as it does in non-diabetics, possibly because of that specific diabetic platelet that tends to be stickier. We don't really understand that fully, but aspirin does not, and that's really an amazing thing if you think about it. Next. So moving on to the other risk factors, as I said, coronary artery calcium score is something that I do very often. In the right age group, obviously, generally I try to do this in somebody over 40 years, although the evidence is more for 60-plus-year-olds. Atherosclerosis, as we know, is a chronic inflammatory process in the arterial wall. And whenever there's a chronic inflammatory process, that begets calcium accumulation. We can do a very simple CT scan to look at calcium accumulation in the coronary arteries and look at the area of the calcium and the density and come up with the score. It's called an Agatston score. It could be 0, it could be 100, 400, 1,000, or even more. And generally, the higher the calcium, higher the risk of coronary heart disease. Coronary artery calcium score is excellent negative predictive value. So a score of 0 gives you a very, very low risk. And anything more than that, 1 to 100 is low risk, 100 to 400 is moderate, anything more than 400 is high risk. Next slide, please. That is how coronary calcium looks like on the CT in your right-hand panel. You can see the coronary calcium distribution along the arteries. Next slide. This just highlights the fact that higher the coronary artery calcium score, higher the Agatston score, higher the risk of coronary heart disease. Next slide. As I said, the calcium score of 0 confers an extremely low 10-year risk of coronary heart disease. And as the calcium score goes up, the risk just keeps increasing. So this is something that's really predictive. Next slide. Also worth noting, not only is coronary artery calcium score an independent risk predictor, it is also a much more powerful risk predictor than all the other traditional risk factors that we talked about, including more than diabetes. Next slide. And finally, the point I want to make is whenever you incorporate coronary artery calcium score in your risk stratification protocol, you will almost invariably end up reclassifying the risk status of your patient that you may have estimated based on traditional risk estimation uh, uh, methods like the Framingham risk score, for example. So all in all, coronary artery calcium score has excellent data behind it. It's very quick. It's a simple CAT scan with about radiation exposure comparable to a chest X-ray pretty much. It takes about 5 minutes to do it, and it gives an incredible amount of information. Next slide. Moving on to PAD and ankle brachial index. This is, again, something very simple that everybody could actually do in their offices. And I would strongly encourage all the primary care providers to get an ABI machine and check ABIs in pretty much all your diabetics, especially people with diabetes who smoke. Obviously, they've got two major PAD risk factors, because the lower the ABI, lower the survival. And we've known this for decades, really. Next slide. PAD has significant 5-year mortality rates over and above many cancers. Next slide. There are many mechanisms by which PAD causes morbidity and mortality, but always remember that the most common cause of death in a patient with PAD is CAD, coronary heart disease. Next slide. So a few take-home points. So a routine annual physical is just a first step in the journey. We definitely need to look beyond traditional risk factors and individualized care. Cardiovascular risk assessment itself tends to be unique. It needs to be comprehensive, multimodal. You just can't look at the heart. You got to look at their diabetes, and you also have to look at other vascular beds like the carotids, ABI, peripheral artery disease, for example. And obviously, we have to appreciate the real risk of diabetes. Sometimes in this blood sugar management, we may lose focus of their underlying cardiovascular disease. Most of the patients with diabetes don't really die of diabetes these days. They die of the cardiovascular issues associated with diabetes. So, and that's pretty much it. I just wanted to keep it short and concise. Thank you.